Hypothermia. Hypothermia decreases renal cortical blood flow by producing vasoconstriction. It also decreases glomerular filtration rate slightly, decreases renal tubular function, and reduces free water and osmolar clearance. These effects are offset to some degree by hemodilation during the phase of rewarming, vasodilation, and hyperemia of tissue beds result in surge spacing of fluid. Hypothermia may also cause hypokalemia due to a transcellular shift. Hemodilation with a crystalloid prime reduces plasma oncotic pressure, promoting movement of fluid from the intravascular space into the interstitial space. A reduction in viscosity increases outer renal cortical blood flow, leading to an increase in urine output, free water clearance, and sodium and potassium excretion. However, a lower viscosity increases outer renal cortical blood flow, leading to an increase in urine output, free water clearance, and sodium and potassium excretion. However, a lower viscosity will reduce sodium blood pressure, systemic blood pressure. A lower hematocrit on pump, below 21% in some studies, or below 24% in others, has been associated with an increased incidence of renal dysfunction. Also, this can be mitigated by increasing pump flow to increase oxygen delivery. Medications. Perioperative medications including amiodarone, angiotensin converting enzyme inhibitors, angiotensin receptor blockers, and calcium channel blockers, as well as drugs and used during surgery, including nitroglycerin, inhalational anesthetics, narcotics, and anxiolytics. Narcotics and anxiolytics can produce significant vasodilation, which lowers the blood pressure and increases fluid requirements. It is generally recommended that ACE inhibitors and angiotensin receptor blockers be withheld the day before and the morning of surgery to minimize their hypotensive effects during bypass, which could exacerbate kidney injury by lowering glomerular filtration rate. Furthermore, use of ACE inhibitors may attenuate the effects of norepinephrine. However, studies have shown differing effects on the incidence of acute kidney injury, with evidence of both higher and lower risks of acute kidney injury in patients taking ACE inhibitors prior to surgery. The potential benefit of off-pump coronary bypass surgery in reducing the risk of postoperative renal dysfunction by avoidance of cardiopulmonary bypass is controversial. Also, a few studies have shown benefits in patients with normal renal function, and one showed benefits in diabetic patients with non-dialysis dependent renal insufficiency. Most studies have been unable to demonstrate a benefit in patients with either normal or abnormal renal function. In theory, avoidance of cardiopulmonary bypass might preserve renal blood flow and glomerular function better by maintaining a higher systemic pressure. It may preserve tubular epithelial function because of decreased complement activation and a lessened inflammatory response. However, off-pump surgery is associated with significant fluid administration, use of comparable anesthetic and vasoactive medications, cytokine release that can damage proximal tubules, and alterations in perfusion pressure. Lower systemic pressures with elevated venous pressures during exposure of the posterior heart, and lower systemic pressures during construction of proximal anastomosis, all of which can adversely affect renal function. Because of postoperative renal dysfunction is related more to pre-existing renal disease or significant hemodynamic alterations than to the inflammatory response, particular attention to fluid and hemodynamic management remains paramount no matter whether cardiopulmonary bypass is used or not. Routine fluid management in the early postoperative period. Hemodulation on cardiopulmonary bypass produces a state of total body sodium and water overload, expanding the body weight by about 5%, estimated at 800 milliliter meter square hour, but quite variable in amount. Cardiac filling pressures usually don't reflect this state of fluid overload because of a capillary leak from the systemic inflammatory response, decreased plasma colloid osmotic pressure, impaired myocardial relaxation, diastolic dysfunction from ischemia reperfusion after cardioplegic arrest, and vasodilation. Low filling pressures are consistent with hypovolemia despite the presence of body water overload, and additional fluid administration may be necessary to maintain satisfactory hemodynamics. High filling pressures may also be noted in the presence of hypovolemia, especially in patients with diastolic dysfunction, and additional fluid administration may be necessary in that situation as well. This fluid requirement occurs at a time when urine output may be high or marginal, below 1 milliliter kilogram hour. During the first 4-6 hours after surgery, cardiac output is often depressed, and the achievement of satisfactory hemodynamics is dependent on both preload and inotropic support. Thus, fluid must invariably be administered to maintain intravascular volume and cardiac hemodynamics at the expense of expansion of the interstitial space. It should be noted that early expansion is helpful in reducing fluid requirements because it eliminates the adverse effects of positive pressure ventilation on venous return and ventricular function. It can be difficult to decide which fluid to administer to maintain filling pressures. Clearly, any fluid infused during a period of altered capillary membrane integrity will expand the interstitial space, but those that can more effectively expand the intravascular space while minimizing expansion of the interstitial space are preferable. Blood and colloids are superior to hypotonic or even isotonic crystalloid solutions in expanding the intravascular volume. Also, a rapid infusion of crystalloid is effective in increasing intravascular volume acutely. This benefit is transient. For example, after 5-minute infusion of 1 liter of lactated ringers, the intravascular volume expands approximately 630 milliliter. Yet, due to rapid redistribution into the interstitial space, barely 20% of this volume is retained within the intravascular compartment after an hour. Similarly, only 25%, 250 milliliter of 1 liter of infused normal saline is retained in the intravascular compartment after 1 hour. In contrast, after a 5-minute infusion of 1 liter of 6% hetastrach, the intravascular volume expands by 1123 milliliter with more long-lasting effects. 5% albumin can expand the plasma volume 5 times more than a comparable volume of normal saline.